Testing 1.
Testing 2.
Testing 3.
Testing 4.
He's got it.
Yeah,
He's got it. He's
Didn't
tuned in. He knows.
didn't
He knows
even
the score.
brief him, did we?
No.
Just straight in.
No.
Welcome to the Testing Podcast, everybody, and welcome, Shafi Wardak. Welcome to the studio. How you doing?
Yeah, good. Thank you for having me.
Thanks for coming.
Yeah,
Thanks for
that's so
taking.
exciting.
Well, it's on your doorstep, isn't it? You're
It
a
is.
local lad, so to speak. Because you're based in Reading, isn't it, in terms of your practice? And,
That's
and your
right.
work? Yeah. So for those that don't know you, who are you and what do you do? Because I missed this with another guest recently on another episode.
We
We
went straight
launched
in.
into the conversation.
like,
I was like, oh yeah, who are you? What do you do?
Yeah.
So, consultant urological surgeon?
That's right, yeah. So I'm a consultant urologist with a special interest in andrology and male fertility management. So I lead a fertility service for the region. We've recently been commissioned by NHS Specialist Commissioning to provide a male fertility service, including surgical sperm retrievals for the Thames Valley region.
Right. So we're going to talk surgical sperm retrieval, and I think we should warn any listeners right now.
If you're having your breakfast and you're squeamish,
exactly.
There'd be a lot
Pause
of
for
men
another
like
time.
crossing
Yeah.
their legs, weren't they? Going like, what?
If you've got meatballs for dinner, and you're listening to this, you might want to.
just you're putting your knife through that meatball.
You might want to pause. Yeah. So we'll get into that later. But yeah, today we wanted to kind of pick your brains and your expertise. We want to talk about azoospermia because I think that we've really discussed this over the couple of years we've been doing the podcast yet, which is that god-awful diagnosis really where a man's told he's got no sperm, which I think is must be life-changing for any man. Because this is ultimately what then usually leads to a microtesia, doesn't it, in terms of then trying to find sperm. But could you tell us about azoospermia and kind of how that comes about, but how it develops or
That's
why?
a pun right there.
Yeah, it is, isn't it?
how it comes about, or not, as the case may be.
So there are lots of causes of male infertility. Azoospermia is really present in about 1% of the adult male population. Not all men who have infertility have azoospermia. About 10 to 15% of men that we see in our clinics with infertility have azoospermia. The rest either have abnormal sperm parameters, reduced sperm concentration, or in fact their sperm parameters are completely normal. The azoospermia refers to absence of sperm in the ejaculate. It doesn't mean there is no ejaculate. The majority of the fluid in the ejaculate comes from what we refer to as seminal vesicles, prostatic secretions. So just having a volume of ejaculate does not necessarily mean that there is sperm there.
I think that's such an important point that most men wouldn't even think about. It's like if they've ejaculated and something's come out, they would presume there's sperm in there, wouldn't there? But
Yeah, the assumption is that, right?
Yeah.
And I
Produce
thought
the
that.
fluid and that's
I
it.
thought that
Exactly.
from my sort of medical history as well. So you know, you just don't know, do you? You think everything's working fine, but you do need to have a test to see whether there is sperm in that ejaculate and whether it's functional.
Yeah, and I think that's a really important point to note for our future social media as well, actually, because it's not something we've really highlighted that much, but it's a really important point to note that actually if you've got fluid there, it doesn't mean that there's any sperm in it, which is quite worrying for some as well. That's quite a scary concept to be aware of, isn't it? But equally why people like you are in this planet to help find it.
And is there a scale of azoospermia? So you talked about low concentrations earlier on, which can obviously impact fertility, but is it a complete absence of sperm in the ejaculate, or is it just where there's low concentrations of sperm?
Yeah, so azoospermia refers to absence of sperm. So there will be no sperm in there. And there's two types. Just over half of these men with azoospermia will have what we refer to as non-obstructive azoospermia. So it's not caused by a blockage. It's caused by a failure of testes to produce sperm. That can either be the testes not producing any sperm at all, or producing very little sperm where it's within the testes, but it doesn't really make its way out in the ejaculate. Just under half of these men with azoospermia will have an obstructive cause for their azoospermia, referred to as obstructive azoospermia. That could be either due to a previous sexually transmitted infection, for example. They may have a blockage at the ejaculatory duct at the prostatic level. They may have had vasectomy, for example. Or there's some men with some genetic conditions such as being carriers of the cystic fibrosis gene, for example, they will not have any symptoms, but there will be no sperm in their ejaculate. And often these men, when they're examined by us, will have absence of the vas deferens, which are the tubes which carry sperm out of the epididymal structure, which is just behind the testes, to the ejaculatory ducts and the outside world, essentially.
Yeah.
So it's almost like either the factory isn't working or the pipework is defective.
Yeah.
I think that's a really good way of putting it.
We keep it simple on this
Yeah.
podcast.
No, absolutely.
Yeah, it's like the
Absolutely.
electrics and plumbing, isn't it? Really?
Yeah.
And
Yeah, this is it. So either it's not being produced or it's being produced, not making its way out. Now, what I was talking about earlier, that in men with non-obstructive azoospermia, where we don't think there's a blockage, we think there's failure of sperm production, there is no way of, unfortunately, knowing whether there is some sperm in their testes or no sperm at all.
sure.
Which is why majority of these men will undergo various type of surgical sperm retrieval procedures.
Yeah. And how would obviously we've just talked about like an ejaculate being produced, like a guy wouldn't really know. Are there any other signs that a guy should be looking at or considering if he's got concerns that there could be a blockage or that he's not producing sperm? What else might be going on for him that would give him an idea?
So the men who have non-obstructive azoospermia, where they've got failure of sperm production, some of them have got other things going on. There's no way of them knowing whether there is sperm in the ejaculate or not. But if their testes have always been very small, relatively speaking, or they've had trauma to the testes where they've lost a testis or both testes. Some men that we see in our clinics, as when they were younger, they will have had problem with testes. For example, one of the testicles, or sometimes both, might have twisted and either have been surgically removed or not surgically removed, but with time become smaller and essentially non-functional. Some men will have had testicular cancer, for example. One of the testes might have been removed. And there's some boys who are born with the testes which haven't quite descended into the into the scrotal sac. The majority of these are operated at a young age, and if the testis is in the groin or indeed even intra-abdominal, it's been brought down. But some men that we see in our clinics did not have that operation.
And I would be one of them. Yeah. Not really tested for it back in the 70s, but I think more frequently it is now, isn't it?
And that's just, we see these men in our clinics, and often some of them already know, and to some of them it comes as a shock that this is something that is operated on early on.
Yeah.
So there's such little awareness around these sorts of factors, isn't there? Just that simple question of, have you had undescended testicles or mumps or an STI? Like, guys don't get asked those questions routinely, do they? It kind of doesn't happen at GP level, and if there are kind of questions over fertility, sometimes it still doesn't happen there. So I think these are really important points that guys need to be aware of, that if it's in their history, they should be maybe checking a bit earlier.
That's right. I mean, this, in the past, it was believed that infertility is really caused by female factors, but we all know that that's really not the case. In up to half of the infertile couples, there is a male factor present responsible for the infertility. And in 1 in 4 of them, the infertility is purely caused by male factors.
Yeah.
So, going back to the normal ejaculate volume, if there is infertility, which is defined as failure to conceive after 1 year of regular unprotected sexual intercourse, and the female partner is going to have some tests, really the male partner should have a semen analysis early on, even if they think everything is normal. Some of those things we discussed, testis size, previous history, none of that's there. The ejaculate volume is normal. They should still have a semen analysis.
Absolutely. You talk about testicle size, and this takes me back to one of our first ever podcasts.
Right.
The rule of thumb.
The thumb.
The rule of thumb. So, because so we've done an Insta Live with a guy called Paul Lewis. I actually did it last night, but whenever this goes out, it would be months ago. And he was a cystic fibrosis carrier. And we kind of had that conversation like, well, we don't know what's normal down there. We know what our normal is as a bloke, but
we don't sit there comparing our.
No, we haven't checked each other's testicles. Like, how do mine compare to yours? So
we don't talk about it, do we?
Should have a break for 5 3.
Now you've thrown me. But you do. You're a urologist. You get your hands on testicles all the time, so you know what they feel like and what's an average size. But your day-to-day bloke has got no idea what normal size is. So when you say small testicles, how would a guy know what normal is? We talked about the rule of thumb, so that from the joint there, the knuckle joint to the tip of your thumb would be roughly average size. Would you kind of agree with that?
Yeah, that's right. I mean, I'd also agree that a lot of men don't realize, even if their testes are small, that they've got small testes for the reason that you've just outlined. Because as part of the history in our clinics, we ask the question and they say, no, they've been fine. And when we examine them, they've actually got very small testes for that reason that you've just described. A testis length of about 4 centimeter is what we would consider normal. But even as urologists and male fertility specialists, with the examining hand, we often get the volume or the length incorrect. So I think measuring it on the length of the finger to see if it's around 4 centimeters or not, half of that perhaps, is probably something that most men can work by. In clinic, sometimes we use oculometers, so you have a feel of the testes and you look at all these sort of beads you have of different sizes.
It's like a nice necklace, isn't it?
It is.
I've seen one of those.
Have you not seen one?
No.
It's like a baby's rattle with just lots of beads on it, but different sizes.
And that gives you like a comparison too.
Yeah.
Yeah,
Yes.
it gives you a comparison of
We'll get
volume,
you on.
doesn't it?
Get you on for your birthday.
Yeah,
It's coming up.
maybe we should get one in for the studio. And,
be quite a good prop,
That'd be quite good.
Yeah.
Odometers.
And some of these men also undergo an ultrasound scan of the testes. I wouldn't necessarily say that they all need it. And again, I don't want to, cause any concern, but overall, the risk of, precancerous and cancerous changes in the testes are a little higher in men who are infertile. So some of these men will end up also having an ultrasound scan, and that gives a very accurate measurement of the volume of the testes, as well as ruling out any lesions within the testes, which may not be palpable, but be of some concern, the majority of which are not cancerous, and we just survey them for a little while, and as long as they're not changing, we can then be reassured and leave it alone.
Yeah.
That really highlights what we've sort of banged the drum of for so long now, isn't it? About kind of, fertility, your male fertility potential and health has that direct link to general health, and cancer being obviously one of the risks that associated with it. And, by us breaking down the taboo of even just talking about your testicle size, how many men may think that they're smaller, but not prepared to go to a GP just to be checked out. And I think that really highlights actually the importance of it, is that yes, you might have children and things have worked out, but actually there could be a direct link of risk of, or a higher risk of things like cancer and other diseases, isn't it? So
that's one of the things that
really
I picked up back in the sort of mid-30s when I had a UTI infection, and then went back to my GP. The GP said, well, actually, I think you might need to go and see a urological surgeon here, because you do have undescended testes, certainly on the right-hand side, and that may need to be seen. And I didn't know at that time. It was perfectly normal for me. I didn't really have any other complications throughout my life. And then when I did get to see a urological consultant, he said, oh, actually, that is inguinal, and you should really consider getting that removed, because it could be a precancerous or have potential for cancer later on in life, because it's not sitting where it should be. So that was a real wake-up call for me. It was completely, from my point of view, benign, no pain, no other issues. But actually, long term, if it was left, could have left, quite some serious complications in the future. So.
That's right. I mean, I think it's forums like this that really helps with awareness, not necessarily just for patients and, partners, our colleagues in the, primary care. It's what I find in my general urology clinics, that not necessarily just fertility issues, anything with sexual health, genital problems, a lot of men don't feel comfortable, discussing that with either their doctor or with, friends, foreskin issues, erectile problems. But once they've been discussed in clinic and solutions discussed, they say, well, it wasn't that bad. Perhaps I could have come forward earlier.
Yeah.
So I think awareness, the reason why I mentioned primary care was because there is very little teaching and training of fertility related topics in medical school and in early medical and surgical training after finishing medical school. So there's very little awareness.
Yeah. Yeah. And I think I picked that up, through my GP. GP really didn't really understand what was going on. It was a bit uncomfortable doing a testicular examination on me. So that was where, I got a referral because of this UTI, but all the issues. And he said, actually, I'm not really the right person, but let's go and get you seen properly. And I think from my point of view, if that was done a lot earlier, then actually, it could have helped my fertility journey a little bit differently from where it panned out. So, but yeah, it's about awareness really, and guys, go and get checked.
Yeah,
That's right.
absolutely. I'm just curious on that point. Actually, you mentioned about kind of the lack of awareness within that professional sector. So how did you get into it? How did you fall into this line of work if the awareness of it professionally isn't necessarily there? How did you stumble into fertility?
What drew you to testicles?
Yeah,
That's an interesting question, and I'm often asked this question by some of my senior male patients when I'm sort of halfway examining their prostate or testes. They're like, "What got you into doing this, doctor?" If you don't mind me asking,
pants are half down.
I think it's very interesting. First of all, it's extremely rewarding that these men trust with quite intimate problems that they have in their health and that you can do something about. Some of the work that I do involves genital reconstruction, and I was always quite drawn to reconstructing work. My interest in fertility and really andrology was developed when I was a trainee in Guy's and St. Thomas's. It's quite interesting because, as I was saying, you don't have a lot of exposure to male fertility training during your training years, except that towards the end of your training, when you have to set the exit exam that we refer to as the FRCS, you really go through everything in a lot of detail. And it was interesting, and it just, sort of things aligned quite well where for the first time, I had a really good understanding of these areas, with microsurgical procedures and sort of hormonal manipulation that we have to do for some of these men. So there was quite a lot of surgery. There was some microsurgical work. And interestingly, we as urologists, although we're urological surgeons, we do like to have an element of, medical work in our practice. And I found that in andrology and fertility with, hormonal manipulations and managing some of these men, for example, with hypergonadism, low testosterone levels, but then also having practical exposure to that work whilst I was in Guy's. As we were talking earlier with the Kleinfelter specialist clinic and seeing these men with infertility and operating on them in an assistant capacity really drew me to it, and I felt that this was something that I wanted to do long term.
Yeah. Your vocation was set.
Yeah,
exactly that. Yeah. And then we had very, helpful senior colleagues and trainers who facilitated in me being able to do a very specialist fellowship at the world-renowned Institute of Andrology at UCLH. So I spent 18 months there, where I, developed some of the specialist work that I now have brought to Thames Valley and do some of this work here.
Amazing.
It is amazing, isn't it? Really.
How you stumble into that world, but it's so life changing in a really positive way that you're aiding men and couples to have a family. I think I think it's such a great gift to.
Must be the most rewarding job, really.
Yeah,
I think. Yeah,
it really is. I mean, I've separated my clinics into certain weeks I see fertility patients, and some weeks I see men with erectile dysfunction and other issues. And all of that work is very rewarding, but I find that the fertility clinic is particularly rewarding because the difference that you're able to make, even when you perform a surgical sperm retrieval and you don't find sperm, and breaking that news, I found, if not harder, being as hard as telling somebody that you've got terminal cancer. Obviously not trying to say that, that the diagnosis could potentially be as, life-changing or life-impacting as each other, but the effect that what the outcome of that procedure has been is immense.
Absolutely.
But even when there is no sperm, our couples normally have that closure, so they know really what it is that they need to do next, whether it's using donor sperm for ICSI-IVF type of treatment or it's an adoption. At least they know where they stand in their fertility journey. Yeah,
it's the worst thing, isn't it, for guys, and many men that we've supported through the support group over the last few years has been very much that no information is the worst thing for them, because it just eats you up with that wonder. Having difficult news like that is, of course, very difficult. But at least it's like kind of, right, that's the line drawn. Absolutely. Now what's the next step? And we always talk about knowledge being power in this space, isn't it? And having that knowledge is really important, despite it obviously being very difficult news to provide and obviously receive. But it's so critical in the next step of someone's journey, isn't it?
Yeah. And I think the issue for a lot of guys is that they completely leave themselves undiagnosed, don't they? If they don't actually go and see the GP in the first instance, and they don't necessarily get to an understanding of what's going on, in your genital area, that's the point at which, it can be really devastating for people, especially if they're excluded from the criteria of going through an IVF program. So getting diagnosed early and actually just helping yourself from a guy's point of view will actually help your mental health as well as physical health in the future. So yeah, it's a really important thing to get doing. And I think the other part is about supporting guys going through that process as well. It's a really dark place. I know I went through a really dark place when I was diagnosed with azoospermia. It was really, really challenging because I just didn't know where to go or what to say. I didn't know anybody else that was experiencing that sort of condition. And even though, I was told quite nicely by the clinic, this is what it is, I just felt as though I was in a black tunnel and didn't know where to come out of it. So having a space like what we've developed here and Fertility Network UK and some of the other support groups that is around is really, really important to get advice. And the most important part is that you're not alone. There's a lot of guys out there that will be experiencing these conditions. So yeah, it's a matter of just trying to get some support following that diagnosis, isn't it?
That's right.
Yeah. Can I just go back to the sort of signs and symptoms? Because obviously the testicles play a really important role in terms of hormones and hormone balancing and hormone production. So again, in terms of what might a guy be experiencing if his testicles aren't working properly or aren't producing sperm, is there going to be an impact on his hormones and therefore his physical well-being and things like that?
Not on all of them, but certainly some of them will have. So testis, as you've pointed out, has got two functions: to produce sperm and to produce the male hormone testosterone, or the majority of the male hormone testosterone. And when there's a blockage problem, then usually the testosterone producing function is also not impacted, as the sperm production function is also preserved. But when there is what we refer to as testicular failure, where the testis is not producing sperm, in some of these men there is also lack of or reduced testosterone production as well, and that can have an impact on libido, erectile function, energy levels, and there's a lot of evidence that long term increases their chance, their risk of other problems like cardiovascular diseases, bone health, and things like that. The trouble, and again it comes to awareness and education, is that men who have what we refer to as hypogonadism, low testosterone level, which they can these days find out from some online tests, which I wouldn't necessarily always recommend, or in the primary care, when they're diagnosed with low testosterone, some of these men go on testosterone replacement therapy. And that can have, although it may improve their hypogonadal symptoms, improve their energy levels and libido and things like that, it will have a negative impact on the sperm production capabilities of that testis. And if they've used the testosterone for long term, those changes may not be reversible. And that can often also be manifested in reduction in the size of the testes whilst they've been on the testosterone replacement therapy. In the men that we see in our clinic who truly have low testosterone and difficulty in producing sperm, they're both testosterone level and hopefully improved sperm production can be achieved in bringing that testosterone level up in other ways rather than putting them on testosterone replacement therapy. So it's really important that anyone who has low testosterone, who has not completed their family, does not go on testosterone replacement therapy before they've met with a male fertility specialist.
Absolutely. That's so important, though, isn't it? Because as you said, there's a number of different companies out there promoting sort of issues in male health and fertility health and testosterone, libido, and various other bits and pieces, but wouldn't necessarily link that to your fertility options. So I completely agree with you. I think you do need to go and see a good andrologist, urologist, or an endocrinologist if you've got any signs of any hormone issues. But you won't know until you go and see a healthcare professional, not just do it online and just think that I've got low testosterone, all the symptoms that you can have a look at, and go and get a test and get testosterone replacement, because that could actually make your fertility a lot worse rather than trying to improve it.
That's right.
Yeah, and how many youngsters out there are in that park where, like looking macho,
go to the gym, make your muscles big.
Yeah. We spoke about, I think, with Jonathan Ramsey before, about how a lot of the younger generation are trying to make themselves look more sexually attractive by being more muscular and macho, etc. But actually what they're doing is harming their fertility and therefore potentially having a risk of not being able to produce children later on in life. And I think that's a really, really important point what you've mentioned. And I'm sure that will end up being a reel of ours, because how many people know about that?
Well, it is. It's all those bulking agents and protein supplements and so forth. They can be endocrine disruptors. And those endocrine disruptors can naturally reduce the amount of testosterone that is either being produced or converted into estrogen, which will have an impact on fertility. So we've got to be mindful of what we put in our bodies, even though we might look good to our female or their counterparts. But it's a matter of just thinking more carefully about it before, especially if you're looking to want to conceive and go down that route.
On that point, up to 40% of the men that we see in our clinics with abnormal sperm parameters, not those who are couples who are infertile, but men who actually are infertile, but also they have, or subfertile, I should say, who have abnormal sperm parameters, we don't find a cause for it.
Right.
So these men have been traditionally, referred to as having idiopathic male infertility. But there's now more and more evidence that, as you were saying, that the majority of these are probably, we've not really worked out why, but majority of them are probably caused by, environmental pollutants and some of those things you were referring to. So I think what we put into our bodies is extremely important. Now, recently I was reading a book called Ultra-Processed People, written by a professor from UCL. And what I found really interesting was, so the book essentially talks about, all the ultra-processed food that we consume and how that's actually responsible for the, the obesity problems we have throughout the world and everything else. And rather than just people's habits changing. So essentially the point he makes is that it's the industry that's driven all of this, and that needs to change. And that, humans for millennia had food that was grown, on Earth, but now actually we eat chemicals that are produced, in factories. And what I felt was that perhaps the decline that we've seen in sperm parameters, where sperm concentration for men has almost halved on average in the last 40, 50 years. That's when actually, all of this fast food and all these starting as well. Yeah. So it's probably not just the obesity pandemic that's been caused by all of that, but also actually decline in. That may not be the only factor, but certainly that would have played a role. Yeah,
there's got to be somebody somewhere must have made a graph of sperm counts versus plastics or processed foods, and you can guarantee
the emergence of mobile phones,
all of this stuff.
Like that.
We had a great episode with Professor Richard Lee, who works in veterinary medicine and has studied all of this stuff, and it was one of the most mind-blowing episodes we've ever had. It's like, oh my god,
I sat there in silence.
yeah. And I sort of said, I think I said on that one, it's like we're our own lab rats.
Well, exactly that.
We're testing ourselves with all these chemicals, and the evidence is there, but it's like we're still just wandering aimlessly into the kind of sperm abyss, really, aren't we? But anyway, we've kind of digressed a little bit here, but that's fine. That's cool. That's what we do. I think what's really important now is I want to explore the options that are open to men once they get a diagnosis of azoospermia, because we have heard this time and time again, and I'm sure you've heard it with patients that eventually have found you and come to see you, that they're told, you're azoospermic, just go and use donor sperm. And it's like, that's not actually that's not necessarily the right first step after an azoospermia.
It's not the only step, is it?
Diagnosis. So what are the options that are open to men after they've got a diagnosis?
Yeah, I mean, you're very right. So a diagnosis of azoospermia does not necessarily mean you not being able to have your own biological child. It may be, but without having a surgical sperm retrieval, you can't really be sure. Unfortunately, that test does not exist to tell you whether there is sperm in the testes that's just not making its way out because there's so little of it, or whether there is no sperm production at all. Some of the tests that we do, there are various genetic tests that we do, and hormonal tests, gives you an indication of what might be going on, but none of it really is conclusive. So most of these men with non-obstructive azoospermia, as opposed to obstructive azoospermia, will have a procedure called microteasy. In the past, these men had just a standard teasy, which refers to testicular sperm extraction, where an opening is made in the testes, and some of the tubules called seminiferous tubule were extracted, and then analyzed in the microscope to see if there is sperm or not. Traditionally, that's how it was done, and often one area of the testes was sampled because you'd open the testes and some of the tubule would make its way out, and you harvest that. But now we use the microsurgical procedures where we use a surgical microscope, where we actually, once the testis is delivered out of the scrotal sac, it's been bivalve, so a slightly larger incision is made in the testis, and the testis is opened almost like a book.
Yeah, here we go. Here's the meatball moment. Step away from your dinner.
So the tubules are stretched, these tubules, which there's quite a few in the testes. And then you look for the certain characteristics of those tubules that gives you a higher chance of finding sperm. So that if they're nice, juicy tubules, then you harvest those. And then the really important person in the operating theatre, although the surgeon may feel that it's them, but it's actually the embryologist, who's sat off, not scrubbed on, in the operating theatre. So the sample is handed over to them, and then they look at those tubules under the microscope, and they often use a needle. And when you look at it in the microscope, the tubule looks a bit like a sausage. Okay, so they just run the needle over it, and if there's sperm inside it, it sort of makes its way out at one end or the other.
That's fascinating.
So it's a bit like squeezing sausage meat out of a sausage.
It's a bit like that, but
It's teasing using a teaser.
Exactly. I've probably exaggerated a little bit. So they do actually cut those tubules into smaller pieces, but so they do part of their assessment there in the operating theatre. And if they find sperm, then you try and harvest some more tubules from that area. So you try and sample more of the testes than you would have done with the traditional teasy procedure that I described earlier. And there is evidence that complication risk, because you're doing it under surgical microscopes, you've got better view, those complications are less. And as a result, you probably harvest less testicular tissue. And you don't want to remove too much because the testes also obviously
you want to restore function
continue to produce testosterone. And also the success rates of finding sperm have also been shown to be a bit higher. So the gold standard procedure for men with non-obstructive azoospermia is a microteasy procedure, which we have now been commissioned, as I was saying earlier, by the specialist commissioning body of the NHS to provide that service at the Royal Berkshire Hospital for the region. So we take referrals from various hospitals in the region now and offer these procedures to our men. We started this procedure about 18 months ago, or probably just a bit over that, at Royal Berkshire Hospital. And the first baby born through this pathway was born in March this year, which was fantastic for everyone.
That's well done.
There can't be anything more rewarding than when you receive a letter from the parent saying, "Well, this is where we are now, and this is what's happened."
It's a big thank you, isn't it?
So. And sometimes it's not good news, as I was saying earlier. But again, that's part of it, and they deserve to know early rather than late whether they have the chance of using, having their own biological child, the man having his own biological child or not, so they can make their plans.
It does provide that closure, though, doesn't it? Really, to understand whether you can have those biological children or not. And that is an important process to go through as well, rather than just being left on the sort of shelf, so to speak, and being those idiopathic male infertility, not knowing, because that will just burn you up later on. So having that as an option is fantastic. So.
Absolutely.
Is microteasy a relatively new technology? Because you talked about a teasy there, so that's kind of where you pretty much take from one site. That almost sounds like a lucky dip to me. You're kind of like, going to the fair when you were a kid and put your hand in the sawdust and hope you're going to get a present. It almost sounds like that, whereas microteasy sounds a lot more, you're actually opening up the kind of the lucky dip, and you can see a lot more. But is it relatively new?
It is relatively new, and in most part of the world, the standard TZ procedure is still performed because the training is not there, the specialist equipment that you need is not there, and in some parts of the UK, it's still performed in that way. And for some men, it may be appropriate, but for most men, the guidelines that we base most of our work on all recommend a micro TZ procedure for men with non-obstructive azoospermia. But as I said, the specialist training that goes with it, and not all centres can offer it.
Roughly how many urological surgeons across the UK are, suitably experienced to offer micro TZs, do you think?
I don't know the exact figure, but andrology in itself, which is a subspecialty within urology, is a relatively small specialty and a relatively new specialty. And then male fertility within that subspecialty, even a narrower body of specialists. I don't know, probably in the region of 20, 25, 30 people probably across the country.
It's low, isn't it?
Yeah.
That's really low in comparison to, say, the female opposite side as gynecologists. There's thousands, isn't there? Or feels that there's thousands, but certainly hundreds of gynecologists out there. So,
and if we're talking, but if we're talking like 1% of men are going to have azoospermia, how many men are going to need a micro TZ? Across the UK, do you think? I mean, just throwing big figures out and big percentages.
So not all of those men will want to have a micro TZ. I've recently had a patient with Klinefelter's syndrome who would have had a good 30 to 50% chance of us being able to find sperm. But they said, thank you very much, I don't want it. That's not something for me. So not all of those men, the 1% men of adult population, will want to have a micro TZ or be offered a micro TZ or actually be seen in a clinic or an environment where conversations about fertility and the chances of finding sperm are actually discussed with them. So it's a national problem, and that's probably because traditionally, for good reasons, for obvious reasons, these couples were seen in IVF clinics by gynecologists who would have had some training in seeing these men. But as you, I think, Toby, alluded to it earlier, infertility in a man or abnormal sperm parameters is a marker of something going on in that man's health. It's not necessarily just harvesting sperm from the testes to use for IVF, for example. It's making an assessment to make sure they're not, for example, a carrier of a cystic fibrosis gene. Because if a man is a carrier of cystic fibrosis gene, they will have sperm in the testes. And getting some sperm out of that testis, because they've got an obstructive picture, will actually be relatively easy because the testis and the epididymis is probably full of sperm. So even under a bit of local anesthetic in an IVF clinic, for example, somebody who's had some training, they will be able to harvest some sperm with use of a needle, for example, and use that for IVF. But if they've not had a urological examination and actually nobody's noticed that they've got both tubes missing, the vas deferens that we refer to, and they've not had a genetic test to see if that's actually caused by being a carrier of cystic fibrosis gene, there is a risk that the IVF, a successful IVF, will result in a child with full-blown cystic fibrosis disease. And what's even more scarier is that cystic fibrosis is the most common autosomal recessive disorder in the Caucasian population. So there is a reasonable risk that the female partner may also be a carrier without knowing. So if the two come together, it will give them a 25% risk of having a child with cystic fibrosis. So that's probably an extreme example of it, but that could potentially what happen. Some of these men may have undiagnosed, STI, for example. There may be other underlying endocrinological problems. So I think we as male fertility specialists need to take ownership of looking after these men. And some fertility clinics are very forward-thinking, and they've actually appointed male fertility specialists, where when a male factor is identified in the couples who seek fertility treatment, they're actually referred to the male fertility specialist. But that's rare.
Yeah. And I think what's also important is getting the history from both sides. So it's like an inclusive fertility, assessment as well. Because I know with infections, for example, they can pass, between each other quite commonly. And whilst it might get cleared up in the female tract, actually the guy might be still suffering from commensal that has entered into the UTI tract and can't get rid of it as easily. So those are the sort of things that need to be really assessed and see whether there is a requirement for medical intervention. And it could be simple antibiotics, couldn't it? That may need to be just considered through that sort of infection screening.
Absolutely.
So what kind of guy, because we've talked about opening out the meatball, what kind of guy expect in terms of that process, and I think importantly the recovery, because we've spoken to quite a few guys that are facing a micro-TZ, and I think, just for a guy to go to a urologist, drop his pants and get his testicles checked is quite a big kind of thing to kind of face, because we're not used to having physical examinations in that way. So the thought of somebody going at your scrotum with a scalpel,
it's quite a scary thing, isn't
that's
it?
really bloody scary.
Yeah.
So kind of it'd be really nice to kind of demystify that a little bit and reassure men that maybe listening to this and I've got micro-TZ booked in a few weeks. It's like, Christ, how do I prepare? What do I expect? What's the recovery like?
That's a really good question. And I think that process starts in the clinic when you first meet them, how you approach the problem, when you're examining them, your examination style, how you explain things to them. So that rapport and that relationship needs to be built earlier. Unfortunately, for various reasons, the state of the NHS is such that there is a lot of pooled lists where, a patient is seen by a physician, by a consultant, and they're listed for surgery and they're operated on by somebody else. And so far, I have not allowed that to happen to any of my fertility patients because of the nature of the problem. I think that relationship has been built from the moment you've met them. And whichever way the outcome of the procedure goes, it's important that they're actually in an ideal situation looked after by the same person. And answering your question specifically about the procedure itself, I mean, it's a day procedure. I would say if you look at the range of the procedures that are done, it's a relatively small procedure from a surgical point of view, not necessarily how our patients would perceive it if they've not had any major surgery before, for example. It's a day procedure performed under general anesthetic often. A small cut is made in the scrotum, as I explained earlier, then a further cut is made in the testes, and then those are sort of closed back. It takes about an hour.
This all sounds so matter of fact.
I know. It sounds
Like,
so
precision
as it
of
should,
surgeons.
you're a surgeon, it's what you do day in, day out. But go on, sorry, carry on.
No, and then they go home the same day.
Yeah.
Oh, right. Wow.
They will have some tenderness, probably for the next few days. Initially, after the procedure, they have some local anesthetic injected into the wound. So the scrotal area is completely numb when they wake up, and they don't normally have any pain when they wake up, and that lasts 10, 12 hours. And after that, normally some simple painkillers like paracetamol and ibuprofen is sufficient, and they don't need to stay in hospital.
Okay.
That's so reassuring to hear, actually.
Yeah.
Having had it done, I almost
yeah,
think
go
about
on,
it.
yeah,
I almost
experience.
think about it now. It's like preparing to go on a flight. So you've got several hours of waiting before getting to the airport. You get into the airport, you check in, you get all your paperwork done, and then you get seen by somebody. That you have to go through security and so forth. And then it comes to the flight, and the flight is relatively short in comparison to getting to the airport, getting everything checked through, and getting out the other side and going through security and getting to your end destination. So that time period of the actual procedure is relatively really tiny, isn't it?
It is.
But as you said, it's a day procedure because you've got general anaesthetic, you've got to take care of the patient, make sure that everything's all in order, all the paperwork's all in order, that you've got the right patients, you've got the right we've got the right procedure,
Correct testicles.
the correct testicles, the right person, and the right date of birth. But the overall procedure is actually really, really short. And by the time you get there and you've seen the anaesthetist, actually you're out, and then you wake up, you go like, is it done? And it's just then about making sure that you're actually okay for your forward travels back home.
So what was your recovery like as a man who's been through it? Come on, you're on the podcast. So
I think what Shafi said earlier on is that actually post surgery, I have felt no pain at all. I felt a bit dizzy because of the anaesthetic and so forth, and had to be driven home. But then over a little bit of time, I think I was advised to have proactively have some paracetamol or ibuprofen, and just to keep that topped up for the next couple of days. So it did feel as though, it definitely felt trauma. You felt as though somebody had kicked you in the nuts, especially as the painkillers were wearing off. But actually, it was okay. It was okay because I think as long as you're explained, you're going to feel as though you've had a procedure.
Know what's coming.
And you are sort of bandaged up a little bit down below to make sure everything stays in place. It wasn't as bad as I'd imagined it could be, but I didn't know what it was that I was having done really, other than I knew it was likely to be painful, but it wasn't that bad.
I'd imagine most men probably think it's going to be the worst possible thing you could ever have
Yeah.
done. So I think if that's your expectation, it's pretty unlikely it's ever going to be that bad, isn't it?
Yeah, because I think when most people have been either kicked in the nuts or something, football, whatever like that. It's horrible and it hurts. And then when you think that, okay, you're going to have surgery on your testicle, you can only just, in your mind, relative to being kicked in the nuts, it must be extremely bad. But actually what you're saying sounds quite
no, it's
normal,
just that
really.
anticipation. It's that anticipation of waiting for the journey and then getting through, having it done. But I think I think one of the most important discussions I had was probably with the anaesthetist, and a lot of support by the consultant as well, in just pain care management afterwards, and just being sensible in the next couple of days following the surgery. If you take that advice, you'll be absolutely fine. But do take some time off work and don't stress and run anywhere or do anything that's energetic, because you will feel that there is
going to be uncomfortable.
Yeah, it's going to be uncomfortable if you try and do something too quickly.
But I love how you, sorry to butt in, but I love how you explain it and you're just so chilled and calm about it.
Yeah.
I think it's such
That's
a
what you
reassuring
want
part
from a
of your
surgeon, right?
yeah,
Yeah.
exactly. Like your
Super
one of your
good
skills
surgeons.
is really important to be obviously very calm. You want a frantic conversation of going, oh my god, I'm going to cut into your testicle. But like it's you're obviously very reassuring to your patients, and it's great that you take them from the very beginning right through to the end. I think that
I love that.
as a guy, you do need that held throughout, and I think it's great that you really enforce it.
It's that reassurance, isn't it? Right.
Having said what we were saying about the fact that it's not a very high risk procedure, it is an operation. It does have risks, and things occasionally go wrong, or the known risk of the procedure, getting a bit of an infection in the wound, things like that can happen. The reason I mentioned that is also extremely important when not to offer this procedure to some of these men.
Yeah.
And that's why some of those tests I was referring to, so there are some genetic conditions which will tell us that a surgical sperm retrieval will be futile. You're not going to find any sperm. So without having done those tests, you might offer surgical sperm retrieval to some men who should have not had it. And obviously that has an impact on that you've offered a potentially problematic, you've offered an invasive procedure to a patient who probably didn't need it, and also its impact on resources. So it's really important that they've been worked up properly.
Yeah.
It's that balance, isn't it, between risk and reward, I suppose,
Absolutely.
isn't it?
Yeah.
Yeah. So what would be a scenario where you've got an azoospermic man and you say no microtesia? We took Sertoli syndrome.
Yeah. So there's we know that the 40% of men that I said have abnormal sperm parameters, but we don't find a cause. They probably also have some genetic and perigenetic causes for the azoospermia that we've just not really identified yet. But the ones that we have identified, I've already talked about the CFTR gene mutations, which results in a blockage type of a picture. And also a condition, some men having a small segment on the Y, on the male chromosome, actually being absent. That's referred to as AZF A, B, or C. These are three distinct regions.
Oh, is this the micro deletions?
These are the microdeletions, yeah. So the AZF, so the azoospermic factor type A, B, and C. And reassuringly, up to 50% of the men who have these microdeletions have got the type C. And those are the ones where you have a chance of finding sperm. And then up to 50% of them you can't find sperm. Whereas if they've got the type A or the type B, then we know that there isn't going to be any sperm within the testes, and therefore they should not be having a surgical sperm retrieval.
It's definitely going beyond my knowledge level here. I've heard of micro deletions. We've talked about it many times, but I've never really understood it fully. But it's interesting to know there's three different levels there, and just shows how important the workup is, and the history, and then the right further testing that's necessary for a man. Because let's go back to the point that I made earlier, that the number of men we've spoken to that have been told they are azoospermic and that's it.
No.
And it's just, there's all this other stuff.
I think that's why, following from what you're saying, I think the danger of having so much access, which can be a good thing, so much access online to a lot of things, and also being able to get a semen analysis without having an explanation of what it means and what needs to happen next, can be a good thing, but also it can be very anxiety provoking. And it might result in some men actually making the wrong decision because they have not made an informed decision. They've not met with somebody who've really given them up. So, for example, I was talking about the low testosterone. They might have abnormal sperm parameters and then have an online test and find out that the testosterone is a bit low, which may in fact not be low. It may have just been checked at the wrong time of the day. And then they may choose to go on testosterone replacement therapy, which people can obtain. And then they would have made their chances of ever being fertile a lot lower.
So what about when it doesn't work? You do a micro-TZ, you don't find sperm, and we've heard of embryologists that have spent hours, literally hours, trawling through the seminal vesicle, not the tubules.
Yes.
And there's no sperm. Kind of what happens for those guys then?
So practically what happens on the day of the procedure, when our patients have woken up from the anesthetic, we will go and speak with them and tell them whether we found sperm or not. So before the procedure, we would have told them that if there is sperm, obviously we'll give you the good news before you go home. If there is no sperm, there is still a chance that they may find sperm or further analysis at the lab. But that chance is not very high. So that we manage their expectation really, because that half a day, I can't even imagine what it might be like for that couple who've got to you after several years of going back and forth, and then you've put them on a waiting list where they've waited a few months, and now they've gone through this and they still don't know for the next few hours. So, and then later that day, the embryologist, having spent however many hours required to assess it as much as possible, and we know that time spent on that part of it is important, and the experience of the embryologist and the lab having all the correct accreditations in place is really, really critically important. And then they inform them with the results. And talking about learning and improving and auditing your systems, from having spoken with my patients and having received feedback from them in terms of because it's a relatively new service we've started, under 2 years. Some of the feedback that I found, which was extremely useful, was that some of these patients, when they were contacted by the embryologist saying that, look, we did not find sperm, were being sort of left to decide what to do next themselves. And they felt that if they had a direction at least, or offer of meeting with with some services that can provide some psychological support, because it can be a very, very traumatic time, will help them. And actually with the conversations we've had with our embryology partners, that's now been put in place, and they're all offered that service.
It's great.
So reassuring to hear,
it is so important, that aftercare, though, isn't it? Whether it's positive or negative, it's a matter of then, what can you do next? Because even just the outcome of having a successful micro-TZ means that, you're going to need to have your sperm sample cryopreserved, and then you need to start thinking about, well, what does that mean in terms of an IVF cycle? Because ultimately you'll probably need an IVF cycle with an ICSI type procedure from that micro-TZ. So, you need to be supported. Both couples, both partners in the couple need to be supported through that next process, because it's not just job done. It's about what happens next, because there are ongoing risks, for that procedure. Even though you may have got some really good sample, you still need to be counselled through that process. So, ongoing support and counselling is really important there.
Absolutely.
I'll tell you what's been in my mind all the way through this is one of our first ever support groups.
I literally had that.
You got the same line, the same
exactly
guy.
What you mean.
Obviously, we won't name him, but
so
me and Toby met and started the first ever kind of online support group for men back with Fertility Network UK in 2020. And within the first 2 or 3 meetings, there was a guy that joined us, and he literally just got diagnosed as azoospermic. And, I think maybe Mikey would have joined by that time, I don't know, or maybe we had Jonathan come in, but, he learnt through that group about a micro-TZ, and he went off and had it done, and they retrieved, I can't remember if it was 5 or 9 sperm, but it literally was less than 10 sperm. he's now got a baby girl,
Wow.
his own biological
Yeah.
daughter.
Amazing.
But what was fascinating about that story was that news that he got broken to him about that he had no sperm in his ejaculate, I believe was the receptionist of the doctors, wasn't it?
Yeah, more than likely.
And I think he went to collect his results, and that was all that he was told at that point, and pretty much was like the silence was
That's
left
it.
for him, and
Yeah, yeah.
he found us because he was just obviously in turmoil. He was just obviously very down, depressed, and what the bloody hell did he do next kind of thing. And I think it was we had perhaps Jonathan Ramsey, I think may have
I think
jumped
he was
on,
our first ever guest. Yeah.
and he was talking about these. We were talking about the topic of Azoospermia, and I think Mike Teasy came up, and it was almost like a light bulb moment for him, wasn't it? And he went on to have that success, and like I think it sticks in my mind as that very first patient that we helped, I guess, from that point, that now has a family,
Just guiding them through a different pathway.
exactly, yeah, and without having any of that education. Had he not found the support group, had he not understood about micro-T's, etc., inevitably may have found it another way, but he may have
He
lived
may not have.
the rest of his life with the unknown of
That's right.
this information, and it's quite scary, but equally great that there's people like yourself and what we're doing here, that actually what we're trying to do is just make sure that people are aware of these procedures and actually how you can completely change your outcomes.
Yeah, demystify the whole thing, and meet very good people like yourself, and offer a different pathway than what may be just present within the general practice or through an IVF clinic. So
Yeah, it's interesting that you and I are thinking of that.
Yeah,
As soon as you mentioned it, I was about to say
it's
myself.
bizarre though, isn't it? The amount of
couldn't
couples that we've met over the years.
Yeah, the stories that they've had.
I mean, I've met a lot of couples, but it's just that awareness. It's just the education, and it's about the right referral pathway as well. So we're very blessed. We know some very good people, but it's not common knowledge out there.
Yeah, and it's
Certainly
also
in
great
general
as well,
practice.
and it's also great as well that you mentioned about kind of the sort of hand holding thing as well, right through all the workup and even post surgery, good or bad, etc. Because we talk a lot about counselling and the psychological effects of men that are going through this, and it's really nice to hear from the professional side, your side, that you're really pro that as well, because. From my experience, and I'm talking about mine only here, is that when I had my failed rounds of IVF, it was just almost like you can have a free counselling session and without any explanation. As a bloke, I was like, I don't need it, I'm fine. Actually, I needed counselling. I had many rounds of counselling. It really, really helped me out, and I'm very pro counselling now. But had that consultant at the time, not forced it on me, but just actually explained the benefits of like these people are here to help you, and I may have taken it sooner, and perhaps it would have helped me out a little bit earlier. So it's really reassuring to hear that you're very pro that, and that you care. Do you know what I mean? It's really
That's
it's really
That's
heartwarming.
It's
really
not just
heartwarming.
an appointment. It's actually taking you through the whole process and seeing you at the other end. So that's really, really well done.
I mean, part of a lot of the men not having access to, appropriate services is, awareness, but part of it is because the services are just not there.
Yeah.
It's a relatively new subspecialty, as I was saying. Previously, they were managed by IVF clinics, essentially. And the other issue is that although a lot of urologists may want to do what we, for example, achieved in Royal Berkshire Hospital, the urologist or the surgeon within the service is I said it in a joking way earlier, but they truly are only one part of a very larger team. The embryology support, and for very good reasons, ensuring that you meet all the requirements, the HFEA requirements, that the clinics you work with meet all of the requirements. Input from our gynecology colleagues, and going back to setting your patient's expectations right and ensuring that what you're going to offer that couple is the right thing. Starts at that very first consultation.
Yeah.
And the other thing that I'm really proud of what we've achieved at Royal Berkshire Hospital is having set up a joint fertility clinic because there aren't many medical problems which involve two people.
Yeah.
And previously we were seeing a man who we didn't know a lot about the female partner, then we would refer them to a gynecologist, say, could you assess to see whether this person's partner meets the NHS criteria of IVF, for example. And there was a lot of back and forth with the overbooked clinics. Now, with having set up the joint clinic, we see the couple together with myself and a gynecologist with special interest in fertility. And most decisions are made in one, or perhaps in one face-to-face and one telephone clinic. So we've actually streamlined that pathway massively by having set up that clinic.
brilliant, isn't it?
Yeah, it's
It
the
is
way it should be
brilliant.
done.
Yeah.
Yeah, really
Yeah,
should
it's
be
like a standard.
across the board.
Yeah, it should be that multidisciplinary approach. It is a team approach, isn't it? And it is the one area of medicine where you've got two people that ultimately you need to assess properly and work out what the appropriate options are for them as a couple. So yeah, it's great.
This has been a brilliant conversation. I can imagine for people listening that are facing this will be a huge reassurance and very heartwarming. And just to know that there's such fantastic clinicians that, you're clearly obviously very skilled in what you do, but you're also very empathetic, very thorough, and really care for your patients. And it's just fantastic. I think it's been a brilliant conversation. So Shafi, thank you so much for coming in, giving up your morning to come and chat with us. How do people find you if they wanted to kind of come and see you for a consultation?
Thank you for having me. I've really enjoyed it. So my NHS practice is at Royal Berkshire Hospital. There's a dedicated page for the fertility clinic on the Royal Berkshire website. There's a lot of information that we've created and put together, how referrals in an area and outside the area are made. And my private practice is through the Forbury Clinic at the Urology Partnership in Reading.
Brilliant.
Excellent.
Thank you so much.
Yeah.
It's
Yeah,
been a
it's
really
been
inspirational
great
chat.
pleasure
This,
to meet you
Yeah.
as well.
Brilliant.
I've really enjoyed it.
Thank you very much.
Keep being awesome, Shafi.
Thank
Yeah.
you.